Assalamu alaikum everyone. Can you hear me?
अस्सलाम वालेकुम बेटे।
वालेकुम सर। सर मेरी आवाज आ रही है?
जी बिल्कुल ठीक ठाक आ रही है।
ठीक है सर।
अभी आपने सारा लाइव कर दिया कि नहीं अभी?
जी सर, ये लाइव चल रहा है अल्हम्दुलिल्लाह मेरे फेसबुक पे हर जगह।
Alhamdulillah, we have started temporomandibular giant approximately 2 months back, and we have covered every aspect of the dental anatomy, and then we have gone for the detail of histology, and we have seen the histological variations of the temporomandibular giant. And then after that, we have gone for the osteology. And complete osteology, we have referred it right from that condyle. Then we have gone for the temporal bone, glenoid fossa. Then we have seen the detailed anatomy of the disc. And for that purpose, we have not only for the microscopy, even for the digital interpretation, as well as for the MRI, for the anterior ligaments, posterior ligaments, and disc own orientation with reference to nerve supply, with reference to blood supply. We have covered all this parameter with on our second, what you say, our season. Then we have gone for the diseases etiology, and we covered all the etiologies with reference to temporomandibular giant dysfunction syndromes, then temporomandibular giant developmental anomalies, the temporomandibular giant traumatic anomalies, and that we have covered in our third season. And in that season we also covered in the part 3 of third season the diagnostic and investigation, and then for that purpose we have gone in detail with reference to the examination, with reference to the history taking, with reference to all the basic investigations, right, starting from OPG, going to P4, then for the CT scan, then for going for the CTBT, and all these parameters we have discussed, and then we have come for the rather direct investigation of temporomandibular giant, that is the P4. Then we have gone for the scantography and orthography and arthroscopy, and all these parameters we have discussed with reference to our diagnosis. And now we are at this stage that we can understand the temporomandibular giant in absolutely a regular way. That we have the concept of its basic anatomy, its all aspects of histological orientation. We have the concept of its development. We have the concept of its orientation with reference to its etiological factors, its diseases parameters, and then we are going to have the good concept of investigation, history taking, and as well as the investigation of the latest concept in investigation. Now, ladies and gentlemen, today we are going to start the management of all these disorders. And this we will cover in 2 sessions. And today I am going to start the first session. And before going to start my first session, I hand over to the main organizer and the chairman of International Association of International Dentists in Pakistan to please say something introductory if you like to have. Thank you.
Assalamualaikum. Dr. Arshad, thank you so much. We started this session anatomy of TMJ, then we covered disease of TMJ, and then diagnosis of TMJ, and now we are going to describe management of TMJ almost 3 months back, and now it is second last session of our TMJ session. Thank you so much, all of you who have joined, and kindly wait at the end of the lecture so that I can describe how to get your certificates. Otherwise, you will not be able to get your certificates. And we will, after this session, conduct a quiz on our website. You will attempt that, and 75% score is mandatory for everyone. Thank you so much. Dr. Shad, you can continue now.
Thank you. Can you do the screen share, please? Screen share, please.
Is my screen share now stopped or not?
Actually, there is no screen sharing is going on.
All right, just a second. Now do kindly. It is.
Bismillahirrahmanirrahim. This is my institute where I am working, and institute is actually now we have a, but secondly you can say the center of excellence for the temporomandibular giant investigations and other thing, and we have the clinics of temporomandibular giants here in HBS Dental College, and sometime there are very good seminars also going on there. Now we are there at the today's session, and that is the management of temporomandibular joint diseases. If you have the concept of temporomandibular joint diseases, then you can understand the majority of the temporomandibular joint diseases are in relation with the joint disc, joint apparatus itself, temporomandibular joint as a whole, then the masticatory muscle associated with it, neuromuscular problems, and these all in combined, they result into temporomandibular joint diseases. And this management is a vision that every general practitioner, every student, and every postgraduate must have in his mind. So our goals are that first we have to reduce the pain and anxiety of the patient. These patients are sometimes reporting first or second visit to you, but some patients, they are visiting you from a long period, and the acute stages, you have the parameter to cover the acute stages in a very accurate way, that patient should feel that he or she is in a safe hands. And for that purpose, the first thing is you have to control the pain. If you are not able to control the pain or the anxiety, that means that the goal of the management is not achieved. Now the second goal is reduction of the functional or parafunctional activities. And these are the basically activities which results from the adverse effect of loadings. And these loadings may be mechanical loadings, these loadings may be psychological loading or parafunctional loading. So you have to reduce all these activities as well. Now, what you have to restore is the acceptable function. Acceptable functions is good mastication, good phonetics, good sleep. These are acceptable function for any TMD or any temporomandibular joint diseases patient. And last is the resumption of normal daily activity. In spite of your all management, if the patient is not able to go ahead for the normal work, you have given such a long or drastic doses of anxiolytic or depressive, antidepressive medicine. Now the patient is in real problem of not to have the active activities of life. And that means that you have controlled the disease, but in such a way that the patient is not able to perform normal activity. So you have to monitor your treatment in such a way that the normal activities of the patient should be right there. Now, after having very good assessment that what I am going to do and what is my management goals, you will consider yourself from where to start. And the start of the temporomandibular joint diseases management is really a task and really a challenge for every practitioner and even for a postgraduate and even for the consultant. So how to start it? Now you have to make a program, and that program should be that the emergency therapy. You will start emergency therapy right here, number one, and you rotate the emergency therapy, which will result into initiation of the initial therapy. This initial therapy, when we will continue this initial therapy, it will result into long-term management. And that is the parameter which every person has to consider, that how I am going to manage the temporomandibular joint diseases. So if we talk of the emergency therapy, this should be in your mind that what the emergency therapy needs. And the needs are that this is the condition of the patient reporting to you. In this condition, the therapy which you require is the reassurance and the patient education. This is a very important thing what you have to do in the initial stages. Second, medication to relieve the pain, analgesic and anti-inflammatory. And how you are going to do it, you have to make the steps that from where to start and where to end. Then you are in such a position like this lady, is severe pain. And for that purpose, what you are going to do, either you are going to give the systemic painkiller, or otherwise you have to inject it right at the place of the pain. And now this painful point may be your joint or maybe any muscular trigger point. and that you have to evaluate why you are doing the investigation or why you are doing the examination or right in the start when you are taking the history. And lastly, you have to release the pressure at the temporomandibular joint. And for that purpose, what you are going to take a cushion, in the teeth, that so that the joint get relaxed. And for that purpose, you are going to give this cushion in a very short time. So the first thing is the emergency therapy. We are coming to the therapy which we want to give. And the first thing which come in your mind is the analgesic. And these analgesic, I will say, start from the minimum analgesic. Don't go for the aggressive medicine. Just start from the paracetamol and then you shift it to mefenamic acid. This I will recommend, that this should be your practice in your life, that you are going to have your medication with the minimum dose, with the minimum drastic potency. And that is what I recommend, that start from the paracetamol, 2 tablets at a time, and ask the patient that this is going to relieve you for the time being. And if you do not get the relief, you can take the 2 tablets when you feel pain again. This is initial stages. Don't try to have the aggressive medicine. Then your target is mefenamic acid. Mefenamic acid is safer and it is a good tolerating analgesic qualities. So by taking the mefenamic acid, I think the generally patient used to report to you more than 60% that they are going to have the relief of the pain. If do not, what you are going to do, you are going to shift yourself to NSAID. Now, NSAID has a long range, and this long range is not meant for you to prescribe every damn NSAID to your patient. Now, selected to NSAID, which I have put it before you, they are potent analgesic as well as they have the effect for the longer duration. Ibuprofen is coming in different doses, right? Starting from 200 milligram, then going to 400 milligram, going to 600 milligram, and even up to 800 milligram. Now, the prescribing parameter is your body weight and the age of the patient and the safety parameters, immunocompromised state of the patient. Already patient is taking so many medicine. Say a person of 60 year taking antihypertensive, taking the drugs like anti diabetic and other many medicine. So you have to very precise enough that you are giving the minimum doses. And I will prefer that don't combine the different analgesic. Say you have taken the ibuprofen and you are adding mefenamic acid with it. I don't think that when one analgesic it is working, you don't going to have the addition of other NSAID. Naproxen is a good analgesic with reference to its long duration, and it is not recommended mostly for the chronic pains. You have to run the patient for the very long period, and that very long period is sometime in years, and you cannot go for this type of potent NSAID to give. Remember these things, that the ibuprofen is very drastic nephrotoxic as well as hepatotoxic, and your parameter should be in your mind that about the drug I am giving, it is safe for the patient. Now, next is that you are going to give the muscle relaxant. Now, cyclobenzaprine is a moderate type of muscle relaxant, and this is only prescribed to the patient when the patient is referring to you with inability of opening the mouth, or you feel the tenderness at the masseter muscle, and you feel the tenderness at the temporalis muscle, and there is sometime you are feeling the hot spot. And we have described in the diagnostic parameters that what is the hot spot. Hot spot is that tender point of the muscle which is being constricted, which is being potentiated by the overactivity of the muscle. And this muscle relaxant should be combined, or I think that it is better to combine with analgesics or NSAID. NSAID, I think that it is better to combine with the ibuprofen rather to naproxen. Metazole alone is also a good muscle relaxant, but its safety is slightly compromised. So for the old patient, we will generally do not prefer that we are going to prescribe this muscle relaxant. So the safest way is that if you are not going to have the relief, and if you are going to have the hot spots of the muscle in temporalis and in masseter, you are going to add the muscle relaxant. But these muscles relaxant must not be added more than 2 to 3 days. After 2 to 3 days, when you feel there is a muscle relaxation is there and patient has came back for its normal function, you are going to stop these muscle relaxants. Now, anxiolytic, what is called diazepam and metalazepam is also being prescribed. These are used with very cautions. And these cautions are especially not recommended, very much recommended in the young patient. You try it in a very old patient, and the patient cannot sleep. The old person after in a more than 60, 65 years of age, and patient is not capable of going to sleep with just analgesic or with just muscle relaxant, you are going to add the anxiolytic. And for that purpose, you just add, start from the 2 milligram and maximum going for the 5 milligram tablet form. I will not prefer for the patient of the temporomandibular joint dysfunction syndrome for the injectable anti-anxiolytic. Now, antidepressant, actually, I will prefer that if anti-anxiolytic is like amitriptyline is a very good antidepressant. But for that purpose, I will rather prefer that being maxillofacial surgeon, being a dental surgeon, or being a postgraduate student, I will not prefer that you become authority as a antidepressant drugs. It is just for the emergency which I am prescribing, I am advocating you. This is just for the emergency purpose. But if you think that patient is definitely a patient of depression and he need to have the psychotherapy, then I will prefer that better send it to psychotherapist or a psychologist, and that is a good approach. But in the case of emergency, you just go for 2 or 3 days, and then is the topical agent. Lignogate patches, they are available and they are very good. with reference to local application at the temporomandibular joint bilaterally or unilaterally, then to the hot spots. And hot spots, as I have mentioned, these are the muscular hot spots, muscular tender points, which patients use to indicate you that in the temporalis muscle, in the masseter muscle, and sometimes in the muscles of the neck, whether it is sternocleidomastoid, whether it is trapezius, whatever the muscle it may be, you feel that patient is given, you can have the lignocaine patches, and it gives the, in emergency, it gives you a very good result. Now, next is the injectable agent. This is rather what you say that it is uh, lignocaine, long-acting steroid in the depot form, or dexamethasone. Now, here comes the question, which to start with. Now, preference is lignocaine because you are going to treat the emergency. You are not going to treat the disease. Now, next is degenerative diseases, old age, and the patient with the previous history of temporomandibular joint dysfunction syndrome, and that reports to you, and that is the stage where you will think of just simple steroid. But if the patient is of long duration and patient is already have been injected any steroid, then you can have the possibility of thinking of depot. And now I will just give you that this therapy should be what you say that every dental surgeon or majority of the general practitioner and especially the maxillofacial surgeons should be capable of giving injection at the level of the temporomandibular joint, and that description I'm just going to show you. Now, this is the place of the joint. You see the feel the condyle. You are just beneath the zygomatic cord, and that is the opening of the condyle. And just you see that you are moving from the tragus area towards the anterior limit. Inject just by inserting your needle not more than 4 to 5 mm. That is your limit, and you inject this right in the superior joint space, and superior joint space you will very easy to understand. Now I just give you again description. This you feel with the index finger. This is your condyle. Ask the patient to open the mouth, place your finger at the condyle, come from the tragus area, and from front to tragus enter into superior joint space. Give maximum, I will say that not more than half cc, or you can say maximum to half or slightly above to half cc, whatever you are going to inject, whether it is local anesthetic agent, whether you are going to inject the dexamethasone, or whether you are injecting a long acting steroid. So that is the important thing that every person should understand, that how to manage the emergency severe pain, and that is a very important task that everybody should know, that I am going to understand. So this is the emergency therapy which, ladies and gentlemen, you have to manage by the systemic way. Now, for the 2 to 3 days, you have to give the soft resilient splint. And that is very easy, that you just take the impression of the upper jaw and make a silicone pressure resilient splint, which is very soft in nature, and which is just you will see again, sorry, This is very flexible, and that flexible, when you apply in the oral cavity, patient is very comfortable and can have the easy bite, and this will give you the emergency relief in the temporomandibular joint for few days. But you are not going to extend this soft supplement for more than 2 to 3 days, because the patient will be habitual to bite on this soft tissue, and it is going to result into micro trauma, and that you want to prevent. So that is the basic thing which you are going to have. Now, this is what we have gone for the emergency therapy. After giving the concept of the emergency therapy, you are going to have the episode of the emergency therapy gone. Now you are going to start the actual initial therapy. Now, actual initial therapy, what should have the after the emergency treatment? It should be reversible, it should be palliative, and it should promote the healing. This initial therapy should be of this three character in it. For that purpose, if we consider that how to move with that, and that is the patient education, and the very important thing is the home care instruction, then is the intraoral appliances therapy, sorry, physiotherapy, pharmacotherapy, and then lastly is the behavior therapy. Now, we start from the patient education, which is a very tricky subject. And this tricky subject is patient dealing and how you deal with the patient. You see, your attitude will be so sympathetic that you can have the conversation with the patient, and patient has the confidence with you, and patient is easily giving you the concept of the contributing factors. And these contributing factors, such as bruxism, I like that, patient feel easy to explain. And then you have to rule out the patient psychologically anxiety patient especially, and you have to educate the patient that the word the anxiety you are feeling, it is going to hurt you, it is going to damage you by hurting your joint and your musculature, and for that purpose you are going to have the patient education. Now, second is the main important thing is home care instruction. This is so important that if all of you are able to give the home instruction, that means that you are capable of giving a real remedy to your patient. These home care instructions should be noted in a patronized way. We have the 5 parameters for instruction with a patient you have to give. And that is instruction with reference to soft diet, focal eye stacks and voice, rest, and especially avoiding the extreme jaw movement, relaxation and stress, and especially reducing techniques. How you reduce the and then lastly is the stretching and relaxing exercises. Ladies and gentlemen, these 5 parameters each should be under your good instruction, what you say, advices. Now, first we take the soft diet. In the soft diet, in the soft diet,
Excuse
we
me,
are
Dr.
going
Rashid.
to have
Excuse me.
a list of soft diet.
Excuse me, Dr. Rashid.
Yes,
I'm going to mute all of them and then I will re-unmute you because
thank
there is
you,
so noise back.
thank you very much. The first thing is eat at least one serving of fruit a day. The serving of the fruit should be in such a way that it is not going to hurt your temporomandibular joint. And that is the main important thing. That select a food which should be easily taken by you and easily can be masticated. Don't take the hard or rough food like apple, like very hard things, and these should be avoided. Avoid nuts, and these are hurting. Avoid sugar cane, and these type of food or these type of things should be avoided, but the fruit should be added in a diet of your patient. One serving of the vegetable, and the parameter is good cooked and nicely cooked, so so that your nutrition with reference to vegetable diet should be complete. Drink at least one serving of dairy food a day. You can take cheese, you can take any dairy food in the form of curd milk, in the form of milk, and anything you like, it should be a day. Then is the eat bread, cereal, pasta, rice, potatoes, and consume at least two serving per day. This is very mandatory that all these food which are mentioned before you, they are soft in nature. They do not require the forceful mastication. This should be in your mind that you are going to serve all those food or all those things which are very promising one and not going to hurt the masticatory apparatus. And lastly, one protein food, and that is well cooked. Especially, I will say meat, chicken, fish, eggs, or cheese. Are these should be very nice cooked, so it should not hurt the temperament. Especially, I will talk of meat and chicken. These are generally, if they are not well cooked, they hurt the temporomandibular joint more. So this is the first thing which you are going to give the instruction to the patient for your diet. Ladies and gentlemen, this diet is why mandatory, because this diet chart you have to give to your patient, because due to pain of temporomandibular joint, patient is generally starving. Patient is not going to have the good food and good mastication, and you, if you are overlooking this first instruction, that is the food, if you are not going to give this in a very nice way, that means that you are not providing good nutrition to your patient, and it may hurt you, hurt your patient health. Now, second thing is that the application of local eye packs and moist heat. This is initial therapy. Ladies and gentlemen, in initial therapy, the concept of moist heat and concept of the ice pack should be in your mind. Say if you are taking the moist heat, that should be for the chronic patient. And chronic pain, why you are giving heat? Because in chronic pain, you need healing. In chronic pain, there is less vascular supply. So you want to increase the vascular supply in that area. By hyperthermia, you are going to increase the vascular supply and you are going to promote the healing. While in case of the local ice pack, it is in the acute pain, and you know that in acute pain what is going to have, there is generally having inflammation, there is more hyperemia, there is no more inflammatory exudate. So for that purpose you are going to make it cold so that the inflammatory effect should be less, and that is generally the patient report to you with acute pain. Now for the moist heat, they are generally available in the market. Some moist heats like this are the electronically controlled by the electricity. These are also manipulated by the microwave application of the heat, and you can place it right there, and you can have this moist heat when you are going to work. Because these chronic pains, they have muscular spasm more as compared to that of the acute pain. So for that purpose, we prefer there should be a moist heat application. So there should be muscle relaxation and there should be more healing process, and the vascular supply should be increased. In case of ice packs, these ice packs are available. You can make your own ice pack as well. And this is in a severe acute pain. These are also available, and these cool packs you can place in the fridge and then you can apply when there is acute pain. And these are generally you request to the patient that you must contain this ice packs at your home or in your freezer. Now third is rest, avoiding extreme jaw movement. No, extreme jaw movement, if you sometimes say, I'm just going to show you that sometimes people used to have this type of wide opening of the mouth, and they do it for fun. Look at this. My God, 8.8 centimeter. That is 3.5 inches. Look at that. And this man, if he is going to have the TMD, then he should not be blame any person, because this whole blames goes to him, that he used to go ahead for this type of wide opening, and you have to instruct your patient not to have this type of extreme jaw movement. Now for that purpose you need to have the relaxation and stress reducing technique. Now this relaxation is like this. You place a very comfortable pillow beneath your neck, supporting external occipital protuberance and supporting the sternocleidomastoid muscle both sides. You close the eye and you relax yourself, and that will give you a very good relaxation in the spans or the masticating muscle. And this you always say to the patient, when you are in the severe pain, you try to go for the relaxation exercises. Now the last thing, and which is very important, which you have to instruct your patient by giving yourself all these instructions. And for this, you all the people, you must understand these exercises. We will take all these exercises today step by step, and I will be happy that if you people will be able to understand. These all exercises are available at the Facebook, and I have a few of them I have taken from the Facebook, and just to give you good instruction and how to give you the better lesson with reference to exercise. Now, this is the first. Stretch your jaw. Place your tongue against the ridges of the incisors and push your tongue against the ridges. This is the first exercise. You can do it yourself right now. Put your tongue against your incisor posterior aspect ridges and push it. And that is basically, you will see it is stretching your jaw right up to joint. This is the first stretch exercise. Actually, this exercise give a very good relaxation to the capsule of the joint. Second is, now you are going to give the stretch by means of putting upper and lower teeth apart by the use of your fingers. You see, I just give you again instruction that I'm sorry, just you one finger down, thumbs up, and you push it like this, and that is recommendation. This recommendation is when there is, you have the pain in opening the throat without any support. This you are getting the support of your finger and thumb in such a way that you are not hurting, but you are supporting the teeth. And by this mean that you are opening the mouth, you are relaxing the spasm, and that is generally recommended for approximately 4 to 5 times. Now, next is, now you relax, and you relax in such a way, you don't push your tongue now, you just relax the tongue just in posterior aspect of the, what you say, incisors. And that is the best place that you close your eyes, take the breath in and out, and relax. These are the first 3 exercises which I have demonstrated to you. That first you are going to have the push of the tongue, then you are going to have the opening of the 2 by fingers, and that you are going to relax by this mean. So this is a 5 minutes exercise, and I think that this exercise is very easy. You can prescribe your patient twice a day. In the initial stages, I will recommend that this initial exercise is very promising one, and patient do not going to have the hurt of more exercises. If these 3 exercises patient used to perform in the initial stages, then it is good. But after 3 to 4 days, you are going to give more exercises to the patient to make the jaw more relaxed. And for that purpose, you are going to give first thing that is by the stretch by the tongue movement. This stretches, you push the tongue forward and then you push the tongue back. By slowly open your move and move your tongue forward and backward. Forward and look backward. Forward and backward. This exercise you will go on, and that is you forward and backward. The next is run the tongue back towards your throat. Like this. You are pushing your tongue right here toward the back of the throat. You push your tongue back to the throat. Sorry. This is the first exercise we have mentioned you, and now the next is run your tongue forcefully to the cheek bilaterally, right and left, right and left. You are going to push your tongue on the right and left way, and that is the main thing. You are going to push your jaw. When you are pushing this side, that means you are pulling your jaw towards this side. When you touch your tongue this side, you are going to pull your tongue this side, and that is the exercise that I just give you again. I side, and then you are going to put your tongue on the opposite side like this, and you are going to pull your jaw right and left means, and that is you will continue this for approximately 2 to 3 times or more. If you maximum 5 times you can do it. Now the next exercise is restricted movement opening. Now this man is putting the thumb at the lower level of the chin and pushing his thumb upward while jaw is opening. You are pushing against opening your thumb. Now that is the resisted mouth opening. The mouth is opening, but you are giving resistance by mean of pushing it up. Jaw is coming down, but the thumb is pushing it up. This is the resisted mouth opening. Then is you can do it by you say by your hand as well. You put your hand down and you put it against sorry. You see, you put it here and push it against the opening like this. Then is the resistance mouth closing. Now patient is pushing the jaw downward while teeth they are going to close. You are pulling your teeth downward and the patient is closing the mouth. Now the resistance movement from side to side. One side you are pushing and jaw you are pushing towards your tooth. You are pushing this side jaw, you are pushing this side jaw, while your jaw is pushing against your hand, and that is the resist to move your jaw side by side, and that is like this you are creating resistance while opening your mouth. Now the next is without any hand, that is right and left movement, maximum right and left movement, and that is the opening and closing of the mouth as well as the jaw side to side. This is another exercise which gives support to the temporomandibular joint. That is feasible that if you do it from 3 to 5 times, and it is very good that you do it 3 times in the morning and 3 times in the evening. Now this is the very good movement for the posture of the giant frontal movement. You see he's moving the front. You can place any stick inside your mouth as well, or other without stick you can move your jaw forward, and that will give you a very good power to posterior ligament of temporomandibular joint. Next is you perform the chin tuck. You push the chin and you move yourself back. As the chin move back, you push yourself back, and that is called the chin tuck. I just again described to you, and that is the chin tuck. Now we are open and close your mouth in a relaxed way. Just open and close your mouth. Just open and close your mouth. This is very good for the maintenance of equilibrium of the joint from right and left side. Sometimes you have the problem with the equilibrium. For that purpose, we used to use the uh, chin tuck again. You see, you are pushing the chin back and your jaw is pushing it forward, pushing the chin back, and jaw is pushing, lower jaw is pushing your finger forward, while your finger is pushing the jaw backward. That is called the chin tuck. This should be done 2 to 3 times, or you can extend it up to 5 times. Now, sometimes there's a midline problem. You push the jaw in a centric way that there should be no deviation, and you place your finger on the joint and slightly push the joint by your index finger, and during this finger opening and closing, you place your index finger right there at the joint and push it toward the medial side. This gives a very good relaxation to the joint capsule, and it is a very good relaxing exercise for the joint capsule, and this can be done up to 10 times, and a minimum 5 times you can do it. And you place your posture like this, anything beside your head, and you push your head beside this thing and maintain your posture posteriorly. This will give you a very good exercise to your neck muscles, especially sternocleidomastoid and especially trapezius. This is a very good exercise by improving your posture posteriorly. This is a very easy exercise, and that is the three-dimensional movement of the jaw in a very slow movement. And that is, you exercise your jaw with the forward motion. You just slightly move your lower jaw forward, and you see that the pencil is coming up and down, up and down, up and down, and jaw is moving forward, backward, forward, backward, forward, backward, and that is the jaw movement. This gives you especially very good exercise from the lateral pterygoid muscle, and it's usually support the lateral pterygoid muscle, and it is a very potent exercise for that. And that is the, what you say, a very good exercise for the right and left movement. It is a controlled movement, and if by this mean you control the joint movement in a very symmetric way. If you have the malocclusion, then this symmetric way exercises are very, you place the tongue spatula right there and you go for a right and left movement, and that is a very good exercise for maintaining both lateral pterygoid and medial pterygoid, lateral pterygoid and medial pterygoid muscle, and it is a very promising exercise. Ladies and gentlemen, these are the soft exercises, and these soft exercises are generally patient used to love them. But when the patient is of a good jaw movement and good for the maintenance of the health of the temporomandibular joint, sometimes fast exercise or increasing jaw mobility exercises will be preferred. Like this, you see, you are rotating the jaw from right to left and then left to right. These are slightly fast exercises, but it gives you the most strength. Right, left, right, left, right, left. This gives you a very strong pull to the both muscle, lateral pterygoid and medial pterygoid. These are the very strong, and even it give the SSC muscle support as well. Another exercise which is fast, it is the forward backward movement, forward backward movement of the jaw in a aggressive way, and that is also giving the support to the masseter muscle as well as the anterior fiber of the temporalis muscle. Then is the round movement with the help of the tongue. You are going to have the round movement. This gives you the very good exercise, for especially for the rotation movement. Now, ladies and gentlemen, at the today, I think it is the sufficient time. I have taken your 1 hour, and for this 1 hour, we have covered the home care instruction, and especially from the initial therapy. And inshallah, next time we are going to cover all the left parameter. And for that purpose, I say thank you very much. And if you have any question, I'm here to answer your question.
And if anyone has any question, you can place in chat box or raise your hand. I will unmute you and or forward your question to Dr. Shad and he will answer you.
I think you can. If anybody can ask, can raise the hand and can ask the question.
हेलो
Yes.
डॉक्टर साहब, मैं ये पूछना चाह रही थी कि मैंने अपनी प्रैक्टिस में देखा है कि हमारे पास टीनेजर जो है ना, वो टीएमजे प्रॉब्लम के साथ बहुत ज्यादा रिपोर्ट हो रहे होते हैं, तो उसके बारे में आप क्या कहेंगे? मतलब उनके लिए हमें मेडिकेशन
Why we were discussing the etiology of the temporomandibular joint, we have
जी, जी।
discussed in detail. I think you have not listened
Yes,
to
I joined.
that basic etiology and diagnostic parameters.
Yes,
And
yes, I
basic
didn't.
etiology, in which we have discussed the anxiety, especially the teenagers. Anxiety is very, annoying for sorry, for
जी,
the
जी सर।
young patients, and especially during exam, their family stresses. For the ladies, especially menstrual cycles and other diseases, like what you say in teenagers, there is increase
जी,
in the
जी सर।
hormones as well, and these all
जी,
things are very much related to temporomandibular joint dysfunction. And for
जी
that
सर, जी
purpose,
सर।
the best thing is the your mutual conversation with your patient. How much you are
Okay.
involved with the patient, and how much patient feel that you are supported to her. And for that purpose, the best thing is that you start with the cold and heat and cold therapy, and then you start with analgesic, not so potent analgesic. Just go for the Brufen tablets, 400 milligram TDS for few days, and then you go for the BD, and then you SOS, and then you ask the patient to have the hot sponging before going to bed and cold sponging in the in morning, and then you can prefer the patient to have few exercises which I have demonstrated to you. And especially if there is any anxiety, you have to get the relief of the anxiety. It is very mandatory.
So there is a question: in emergency situation, cannot we reduce TMJ manually?
The next time which we are going to have the initial therapy, that manipulation by the dental surgeon, that is physiotherapy, I say, That is with the exercises we have just instructed. This is done by the patient. It is not by the dental surgeon. And in the next session, which we are going to have after 15 days, we are going to demonstrate what the exercises patient the doctor is going to give by his own hand, like physiotherapy. With physiotherapy, patient we are going to give to the patient.
Alright, there is another question. Sir, could you elaborate how do changes in menstrual cycle cause TMJ dysfunctions?
Menstrual cycle, actually estrogen's level is in the initial stages it is very much high. When the progesterone comes, the menstrual cycle used to reduce, but this progesterone cycle, when it is initiated, the pain stimulus and muscular spasms throughout the body is slightly increased. And if you are under the stress or under the anxiety, this spasm is being what you say is exaggerated by this menstrual cycle anxiety. So that's why the menstrual cycle results into more severe episodes of the temporomandibular joint if it already exists.
Alright. If anyone has any question, you can put in chat box so that we can close the topic. And if anyone has not attended any of the previous lectures, you can go to our YouTube channel or Facebook page. You can find everything there.
I can see one question that is regarding tetanus or what? How to acha. There was one question regarding to did the hormone effects to TMJ pain. There are so many hormones, and every hormone do not play an important role. It is the related to the hormonal deficiency. It is related to hormonal hyperactivity. These both act by all the means to affect the temporomandibular joint disease if it is already existing.
There is another question. Will emergency therapy be the same for patients with tetanus?
No, tetanus is you have to understand the temporomandibular joint dysfunction syndrome or trismus of the temporomandibular joint. Then is the tetany. This is due to calcium and calcium gluconate deficiencies and other factors deficiencies. And then there is tetanus, which is Clostridium tetani. This is the basically it is due to that. So these are all the three things are definitely different. The one is due to the muscular spasms due to certain deficiencies that is called tetany. And tetanus is due to lack of the motor neurons due to the tetanus itself. And what the muscular spasm with the temporomandibular joint is an entirely different thing. These are the bundle of the hot spots in the muscle which are going under the tense constriction or the nodular formation or the hot spot formation in the temporomandibular joint. No, these three things are entirely different.
For the edentulous patients, exercise would be the same.
Actually, the edentulous patient generally do not get the temporomandibular joint dysfunction syndrome. They generally get the problem with that of superluxation or dislocation. Joint problem is generally not there. It is due to already they have the no vertical problem and no vertical stability. So generally there is a no what you say the TMJ dysfunction syndrome type. It is the function degenerative diseases are there. the joint rubbing is there, lack of the joint, what you say, activity is there, but they generally do not have this type of temporomandibular joint dysfunction syndrome as the adult or dentate has. So these exercises generally they don't require. They generally edentulous patient require the full denture, and if the person has the full denture and he or she has the pain in temporomandibular joint, that mean maybe it is related to the any vertical height, any high vertical height or low vertical profile, which is hurting the temporomandibular joint. We have to correct that, or it may be not a good occlusion or centric occlusion or good functional occlusion. These all parameters are related with the denture related anomalies, and generally they do not go for the temporomandibular joint itself problem. There is
All right.
any question from the Facebook?
No, there is actually no question for now. If there will be any question, I will forward you in the next session. Hope so we will start with that those questions.
Thank you very much. I am very much thankful to, especially to Association of International Dentistry, and I'm thankful to the management and ICD, International College of Dentists Section 24, for organizing these um, webinars, and especially to the organizer, and that is the excellent one. Thank you very much, and inshallah we will go for the, this will be our last session, and inshallah we are going to have this last session, we will going to complete this temporomandibular joint in every aspect, and if you have any question, we will take that day the full answer and session, what you say, seminar, and after the lecture, and we will inshallah I will try to answer your every question. From that I it very much thankful to all of you.
Thank you so much, Dr. Arshad, for your nice webinars. And a request to everyone, kindly follow our Facebook page so that you can be updated with recent updates and old updates also. You can join any of the session which has passed. You don't worry, everything is available on our YouTube channel and Facebook page.
Thank
Link
you
is
very much.
available in chat. Thank you so much, Dr. Arshad.
Thank you.